According to the World Health Organization, currently 171 million people worldwide have some form of diabetes, and the number is expected to double by the year 2030. What is causing this increase? Who is most at risk? And what can be done to stop the spread of this killer disease? Tonight, an ever-growing epidemic. I'm Ernie Manous, and this is Houston 8. Joining us tonight are Dr. Evangelina Trejo Villagomez, research scientist, Methodist Hospital Research Institute; Dr. Jay Morris, President, Houston ADA Leadership Council; and Dr. Lawrence Chan, Director of Diabetes and Endocrinology Center, Baylor College of Medicine. Thank you all for coming tonight. The first important thing, I think, is people hear diabetes all the time, but they don't even understand what that means. And I'll start with you, Dr. Chan. What is diabetes?
Well, diabetes is basically defined by the fact that, initially you have sugar in the urine. That's what first, helped us make the diagnosis in the old days. And when you eat, your food is turned, digested, and then turned into sugar to maintain energy, in the body. And there is a hormone, insulin, made by the pancreas, which keeps the blood sugar normal. It helps the blood sugar to enter cells and provide the energy. In diabetes, either you don't have enough insulin, or the insulin that you have in your body is not working properly. Then you cannot drive the sugar into the cell, and then your blood sugar builds up and it spills over in the urine, and that's what we call diabetes.
Dr. Villagomez, why is that a problem? What then happens if your blood sugar is off?
Well, you get an assorted array of issues because you have this metabolic derangement, basically, of the inability to metabolize carbohydrates primarily, but even proteins and fats. So the body has to find energy sources one way or another. And all that the body understands is the cells are starved and their cells are dehydrated. And so it'll, and there's this hormone, glucagon, and also that's produced in the pancreas that will start to, tell the liver to break down sugar that's stored there. So you already have high blood sugar, and then you have another mechanism of breakdown of more sugar that just continues to accumulate. And a number of other processes occur. And depending on the type of diabetes and depending on the severity and depending on the age of the individual, it could lead to the point where the individual might even use fat for food. You've got to get, like carbohydrates normally are converted to glucose 100% of the time. And proteins maybe about 60% of the time, and fats a lot less, maybe 10% of the time. But this derangement causes the body to start utilizing protein stores, for example, because it can't metabolize carbohydrates well. And the protein stores are obviously on muscle tissue and visceral protein. And so the person, whether they're obese or they're already thin, tend to lose an enormous amount of muscle mass or weight in that sense. And then, as I was alluding to, then some of them, either they don't produce any insulin at all, like in type 1 diabetes, or they're very ill, very sick, very infected, or have major trauma, and they might also convert fat for food, which leads to acid in the blood. And you can't have acid in the blood because then you have problems with cardiac, contraction of the heart tissue. But again, you're looking at electrolyte imbalance, intracellular dehydration, and that's why people feel fatigued and exhausted and hungry and all those kind of things.
And I would just take that one step a little bit further,
okay,
because of the sorts of chemical derangements that happen in the body, and because every cell in the body uses this sugar for energy. The derangements impact basically almost every organ in the body, from the eyes, the heart, the kidney, the blood vessels. So it's a disease that these biochemical changes has a devastating effect on most of the organs in the body.
Okay, let's talk
I
a little simply
add to that.
Okay.
The reason is, Evangelina brought up, a very complete story. But nowadays, the major cause of diabetes is so-called type 2 diabetes. That's when the insulin's around, but it's not working well, and that's what we call insulin resistance. So the body cells do not respond adequately to insulin. So even with the elevated
type 2.
So this is
separate them for me so I understand the difference.
Type 2 diabetes is caused by a combination of two defects. The body produces insulin, but the insulin itself doesn't work well because of insulin resistance. In other words, the body cells and organs don't respond adequately to insulin. So normally, if everything's okay, your body produces more insulin to overcome that defect. As people become overweight, I'm not quite finished on type 2. But when you also have a genetic predisposition so that your body cannot overcome the insulin resistance, then you have relative insulin deficiency. Although you're trying to make more, you cannot make enough. Then you develop diabetes. Type 1, on the other hand, is absolute deficiency of insulin, so that you produce hardly any or zero amount of insulin. Then even though you have no insulin resistance, you develop high blood sugar and you have diabetes. And that affects children, kids.
Strange question then here. Why are they both... They sound like very different diseases. Why are they both diabetes?
The end result is the same.
Which is?
Which is the elevated glucose and the chemical abnormalities that Dr. Villagomez was talking about.
Okay. So for every degree of increase of blood glucose as determined by, we use this measure, hemoglobin A1C. A lot of the patients with diabetes understand that. But hemoglobin A1C is a percentile score of a reflection of their glycemic control for the past 3 months. So everybody needs to know this number, and they know this number is called, that's their diabetes control. So for every degree to which that percentile score increases, you have coexisting inability to dissolve clots. So in other words, the higher your blood sugar goes, the more clot formation. So that's why the majority of people die from heart attacks and strokes. So it's just an inability to do that. And then...
Is there a connection between high blood pressure and diabetes?
Yes.
What's that connection? How does that... If you have high blood pressure, are you more predisposed
not
for diabetes?
Not everybody that has diabetes has high blood pressure, and not everybody that has high blood pressure has diabetes. So I think we do oftentimes see them coexisting. We call that comorbidity. But I want to go back to what you were talking about just a minute ago. The end result for both type 1 and type 2 is just this abnormality and the difficulty controlling your blood sugar, which then has a whole sequence of events that evolve over time. But also going back to something that you mentioned earlier, the real epidemic in diabetes is in type 2 diabetes, and that is primarily related to obesity. And so what we're beginning to see an increased incidence of type 2 diabetes and diabetes in younger people.
Let's talk a little bit about the obesity factor, because I think a lot of people hear diabetes, they think it's the fat person disease. Why is it in obese people? What is it about the chemical makeup or the physical makeup of somebody who is overweight that leads it more easily to being diabetic?
When you become overweight, your body, the organs, and the cells become resistant to the action of insulin, so that the insulin that's circulating is not as effective. As I said earlier, normally the response of the body is to produce more insulin. But in certain individuals, people with some genetic predisposition, the body is unable to produce the extra insulin.
Do you have to have a combination of the two, the genetics and some physical abnormality to get it?
Yes, you do. Many people are overweight, but not all of them are diabetic. But things are getting worse in the sense that the obesity epidemic is becoming so bad that many people are extremely obese. There is a certain point at which very few people can really maintain their blood sugar when they're extremely obese. But initially, if you have some obesity, not all of them will become diabetic.
Dr. Villagomez, it's kind of a strange question, though. Is there a different kind of obese that's better than another? Are people that are becoming obese on a lower quality food, a higher fat food, are they more predisposed to getting diabetes than somebody who is...
Fat cells in themselves, as he mentioned, cause insulin resistance, and meaning that the cells are not able to utilize insulin, particularly the muscle tissue and the liver. And so a lot of the medicine for someone that's overweight or who has type 2 diabetes or has prediabetes is moving your muscle groups. It makes insulin more sensitive when you just move your muscle groups. It tends to sensitize them a little bit more. So if for example, at that point that the patient is overweight, the other things that occur when insulin becomes insensitive to be utilized by that individual, it goes into what's called like an oxidative stress type of issue. And these are people who are not even diagnosed with diabetes and may or may not have alterations to the glucose metabolism. That is, they don't have prediabetes yet. Just being overweight in itself, puts someone in this inflammatory state that's already making insulin resistant. So you have someone with a Hispanic background or an Amerindian admixture background or an African American background. They've got some genetic admixture that doesn't allow them to utilize insulin well at the cellular level. So you're trying to get the insulin to hook up to carbohydrates, as an example, take it into the cell, produce oxygen and energy. Well, right at the level of the cell, there's receptors there that should be present that insulin cannot go in there unless those receptors are present to act as a door to get the insulin in. So as he mentions, the body has to compensate by producing 5-8 times more insulin. As a patient is going from being overweight to pre-diabetic to diabetes, it's because this inflammatory response is causing this increased insulin level. Insulin in the body typically converts the patient to gain more weight. The more insulin you have, the hungrier you become, the more weight you gain, the more weight you gain, the more resistant you become, the hungrier you become.
So
it's a vicious cycle. So that definitely, and it's in the postprandial state, that is on the fed state or the point when somebody eats, that's the most difficult time and a more stressful time. Because when you're fasting, it's easy for your body to compensate to normalize glucose. But feed someone and then test their blood sugar 2 hours afterwards to truly find out if they have metabolic derangement, maybe prediabetes and maybe diabetes state, because that's very difficult because people are resistant, especially if they're overweight. Typically, if they're overweight, that's what you want to do, not only test their fasting, but maybe test their 2-hour glucose or let them check their 2-hour random glucose, because as the blood sugar goes up 2 hours after they eat, so does the insulin level has to compensate. The higher the insulin level has to rise, the higher the cholesterol, postprandial, the higher the blood pressure can go.
Okay.
It forms atherosclerotic plaques at the postprandial
Let me ask Dr.
state.
Morris this then. Hold on one second. Let me get Dr. Morris. We'll come back up around. I'm curious then, so if you're predisposed because of genetics and you become overweight, that kind of begins the chain reaction.
Exactly.
If you don't have the genetic predisposition, but you become overweight, can you still become diabetic?
I'll probably defer to Dr. Chan on that one.
Okay. We're back to you after all.
My experience has been that just it is the combination of the genetic predisposition and being overweight that really is most likely to end up with you becoming diabetic. But you don't have to have the genetic predisposition to become diabetic. So I don't think it's, in my opinion, it's not a good idea to get hung up on the genetic component of this.
Only because I think it is, in a sense, to be hung up on the genetics, just because the majority of people in this country, the fastest growing population is Hispanics, and we're going to have a really big problem.
So that's, I agree.
We'll get to Dr. Chan.
Yeah.
Okay, so I'm going to talk about two issues. One you brought up earlier. You said, is there any difference in different types of fat? I think there is. The body, in terms of obesity, there are two forms of obesity in general. You either look like an apple or you look like a pear. Mm-hmm. An apple is, with a big tummy and small hips. A pear is relatively small tummy and big hips. It appears that apples are more prone to develop all the diabetic complications, diabetes, so they're more prone. So in that sense, different types of fats seem to matter. In terms of genetics, we have to understand that the reason that we think genetics is involved is we do see two people who are equally obese. One person might have diabetes, the other one may not have diabetes. It doesn't necessarily mean that that one may have the genetic disposition, the other one doesn't have. So in practice, it doesn't matter. You treat the one with diabetes and not the one, you treat the other one with a different approach, trying to get him to reduce weight or him or her to reduce weight, etc. The reason we know that genetic predisposition is a very important underlying cause is because of all the genetic epidemiology studies, which show not one gene but multiple genes, so each gene contributes somewhat to the predisposition. It's a combination of factors. In fact, in the last, say, 5 years, we've mapped over 10 to 15 genes that are mapped with type 2 diabetes. And most of them, the vast majority of them, have to do with the pancreas, with the insulin secretion, not with insulin resistance. There are one or two that may be related to insulin resistance. The vast majority of the genetic predisposition works through the pancreas, the ability to secrete insulin. That's
okay,
why.
Let's do some Diabetes 101. Simple, basic answers that the audience, I'm sure, are wondering. What are the signs? What are the symptoms that you should be screened? Start down there with Dr.
Well,
Morris.
I think the first thing that you should consider is a good physical examination on a regular basis. When I was treating patients, I was asking them to see me on an annual basis for a physical exam, and it was during that physical examination that I would test their blood for fasting sugar. In addition to that, in the emergency rooms, we would also see people come in with the classic sort of symptoms of diabetes that was undiagnosed, and now the sugars were out of control. Typically, we call it polyphagia, polydipsia, and polyuria. Polyuria means you're urinating a lot. Polydipsia means you're eating a lot, and which one did I forget? Is drinking a lot. So you're drinking a lot, you're urinating a lot, you're eating a lot. You may have visual symptoms, blurry vision, because the sugar that's in your eye lens causes the lens to swell, and so you may have blurry vision as well. So those would be things that would be that if you were seeing somebody for symptoms, you'd be suspicious and want to screen them. But I think everybody should be screened on a regular basis with
Some might not
physical
have any
exam.
symptoms.
Is there a point where you can reverse? Once you are diabetic, are you diabetic endgame, or can you reverse it?
In some individuals, you should be able to reverse it. For example, somebody who's overweight or obese, to try to control the weight and get them, theoretically, if you get them back to normal body weight, some people may still have diabetes, but some people may lose their diabetes. So it is possible to reverse, especially in early stages.
Yeah, I was going to say, the longer you are diabetic, the harder it is to go
back. The less likely it is for you to reverse.
Or the pre-diabetic phase, when your sugars are out of control, but you're not at the point yet where you could meet the criteria for the diagnosis of diabetes. I think that's
a good point.
During that phase, it's been my experience that if you get people to get active, they start paying attention to their diet, losing weight, that sort of thing, that you can regress back to a normal state and not be considered pre-diabetic anymore.
Dr. Villagomez, you made a point earlier to talk about the Hispanic community, the African American community. Why are we seeing it in these pockets?
Well, first of all, it's just the typical growth that we see through the census tracts, through our communities and so forth. And the fact that we don't truly understand all about the genetic issues that they have. They have located some, variation on chromosomes in Hispanics and to try to explain the severity and the prevalence. But when you look at Hispanics, not only there's so many of them, but the problem is, and the majority have diabetes. You compare it to, like, in general, there's type 2 diabetes or diabetes in general, maybe 8% in the country. And then in these groups, you start looking at 15%, it could be 16%. You go to Stark County and some of the borders of the state, you're looking at 50% of the population either has diabetes or first-degree relative diabetes, and with diabetes. And so it becomes very complex because you have associated rates of poverty, illiteracy, and all that's adding to the complexity, because when you deal with diabetes, there's at least 10 conceptual areas that have to be addressed for diabetes self-management training for these individuals. You have to be able to address them in their language, the type of Spanish that they speak, what foods they eat, address them where they are in their churches or in the communities. And so it becomes a little bit more complex to try to deal with, culture, language, genetics. And on top of it, the complication rate is 8 times worse. So you'll see a lot of microvascular complications, that is, where they're blind, they have amputations, they have renal failure. In Hispanics, quite prevalent. It's a prevalent situation, and that's costing the state and the country from a health economic point greatly. It's a great burden in that sense.
Is this a new disease? Is this new to the human race, or has this been with us
forever?
It's not a new disease.
Since the beginning of time.
Why the growth now? Why do we see, like in the top of the read of the show, I said it's going to double by 2030?
Correlated with technology. So technology, we're thinking, is our friend. Technology actually decreases the mobility, obviously, and the fast pace at which we live. We have no choice but to eat the fast food. And as soon as people cross the borders that have Amerindian admixture, Asian blood, or Latin origin, or African American, like or even Japanese, once they cross the border, things change in this country. The culture of the United States is such that
it's correlated with the obesity epidemic.
As we get to Dr. Chen, I'll get back down here in a second.
A lot of this is environmental. With the in the say 40s or before, when food was scarce, in general, then there was a very low prevalence of diabetes. But with the improvement in food availability and with the changing lifestyle, it's becoming an epidemic, because we are now, the weight has gone up for everybody, and then it's continuing going up, and the genetic predisposition hasn't changed in that sense, because you don't change genetics overnight. But then, because of the increasing obesity, then more and more of the population become diabetic.
We talk about the Hispanic population having a higher. Well, if you go down into South American countries, do they also have a higher rate of it there, or is it just American Hispanics?
Hispanics in the United States especially have a high prevalence and incidence of diabetes. In the other countries, it's not as great a change. The reason being the changing lifestyle here. For example, people of Hispanic origin, Mexican Americans, when you look at them in the 50s, they used to walk to work even in the United States. Nowadays, they drive a pickup truck and they eat big hamburgers. Now the drinks in McDonald's is 20 ounces instead of 13, which is the traditional.
Is it wrong to look at it as different ethnic groups, or is it socioeconomic? Is it lower income have higher rates, or is it Hispanics, African Americans, poorer Americans? Just
it's a combination of factors. They are all related, environmental, plus some genetic predisposition. But genetics applies to everybody. For example, East Asian Americans, who move from Asia, from China, from Korea, from Japan, to Hawaii, and then some to mainland United States, the prevalence of obesity and diabetes goes up when they move to Hawaii, and goes up further when they move to mainland United States. So although they have the same genetics, they are predisposed to diabetes because of the changing environment.
Dr. Morris? Yeah. Jump in
there. I completely agree. I think there are also cultural issues related to diet that play a role here with the typical diet that the Hispanic population would eat, and so it's a multifactorial. There are a number of different things that come to play.
But if I'm listening to all of this and I think to myself, well, if I eat healthy and I exercise and I do the things that we've all been told to do to live a good, healthy lifestyle, this won't be a problem for me. Is that a safe assumption?
That's me. I have a diabetic predisposition. I have both sides of my family has diabetes, and I'm already 52. I don't have diabetes, but you have to fight at keeping your weight down. Like, for example, you have to know your numbers. You have to keep your waist circumference, less than 35 if you're a woman in particular. and you've got to keep your blood pressure, 120, 130 over 70 over 80. You've got to keep your blood sugar fasting under 100. Anytime it goes over 100, that's abnormal. And you have almost the same risk factors as someone who is already diagnosed with diabetes at 126.
If you aren't diagnosed, you don't have, can you still get glucose meters and still check this? Is that something people do or
if
no?
If you're not diagnosed?
If you're not diabetic.
Oh,
if you're
of course.
just concerned, worried,
you'd have
want
to
see.
pay it out of pocket, but there's so many people who have diabetes you could borrow one. It's all around you. Yeah,
That's
no
Jen.
problem.
I want to go back to the
30 seconds to do it.
predisposition.
You're telling
I
me.
want to talk about one very briefly a study. Somebody with pre-diabetes, different groups of people, they treat them with either with no treatment, just some advice, and then with medication, metformin, or with lifestyle changes so that they exercise and diet and do it right. The most effective is lifestyle changes. The next one is metformin. And then
We're just out of time, so if you can tell me in a minute and a second, you can do it.
The extension of the study, when they did it in people with a genetic marker for diabetes, the lifestyle changes could prevent diabetes in the pre-diabetic
So
group.
walk 10,000 steps a day.
All right, we are out of time. Thank you all for joining us. Thank you for joining us, and join us back here next week for another episode of Houston 8. Thank you. Have a good week.